This case is about a 71-year-old female with scoliosis and postural collapse. She knew she had scoliosis her entire life, from teenage years. It really started to bother her about 5 years ago when she started to notice a decline in her posture, where she would started to hunch forward more and more and more. It started to give her some low back issues, pain, some soreness, some sharp pain as well, traveling down her legs. But the biggest thing for her was that she's starting to lose the ability of walking as much as she wanted to. Let's find out what we have on the x-rays. All right, so this is what we found on the initial x-ray analysis with this patient. The first thing that we noticed, obviously, is that very severe left lumbar scoliosis that we measured at 50.3 degrees with the Cobb angle. The second thing that we noticed with this x-ray as well is obviously that there is a lateral slippage of those vertebrae, which is what we call a lateral spondylolisthesis, which is when the vertebrae are slipping from side to side. That creates a lot of instability locally, which also creates more pressure, more tension, and accelerates the wear and tear of those joints. The third thing that we notice is the fact that we're starting to see some osteophyte formation, which is basically extra bone formation just to try to work against that instability. And the last thing that we notice as well is the fact that the pelvis is really tilted on that left side. There's a major sacral discrepancy that we noticed. On the second x-ray, we'll see why that happened in the first place, but that very big pelvic tilt, which is basically the foundation of your spine, creates or leads that spine to bend onto that left side. So this is what's really complex and interesting with this case is this presentation here. This is the same patient seen from the side this time, full spine. What we notice the most, obviously, is that the fact that this red line here is absolutely not matching the green line. As we can notice here, we need a certain amount of curves in certain areas of the spine to make sure that we have proper functioning, proper nerve flow, make sure that the muscles are not being too tight, not too much tension on them as well. And what we notice the most on this x-ray here is a complete reversal of the lumbar lordosis, meaning that you're supposed to have a little bit of an arch in low back. In her case, she's completely hunched forward from the tailbone all the way up to the shoulders. In her case, because of that, it creates more pressure on those discs, more pressure on those nerves, and that's the reason why over the years, with abnormal pressure, abnormal wear and tear, we're starting to have that degradation, that collapse of the posture, and in her case as well, low back pain, stiffness, more soreness, more fatigue, difficulty breathing, and in her case as well, difficulty walking. So on this x-ray, which is what we call an A to P modified Ferguson, anterior to posterior, is the x-ray view or x-ray analysis that we use to measure any type of pelvic tilt, sacral discrepancy, and ultimately the difference in length between the right and the left femur. In scoliosis patients, this is really important because lumbar or thoracic scoliosis or curvature depend on how well the foundation of the spine is maintained. In this patient case, what we notice the most, obviously, is that huge tilt on top of the tailbone, on top of the sacrum, which leads to naturally that body to adapt to that weird positioning, and that's the reason why she presents with a severe scoliosis. We also notice that her left femur sits lower than the right one, which means that she naturally has a left leg shorter than the other, which also led to having that deeper tilt as well down there. With this patient, we decided to go with a bracing option. It will be a combination of ScoliBalance program, which is a neuromuscular reeducation, which is basically specific exercises for postural changes. We're going to add some spinal manipulation to increase movement through the spine in very targeted areas. In her case, it's going to be SI joints, low back, and upper back as well. And then we're always going to finish that program with what we call mechanical traction, which will place the body in opposite image or mirror image to create that extension in her low back, opening up those joints and opening up the chest as well. So progressively over time, we can teach those muscles and those ligaments to hold their position a little bit better. For this patient, we chose a brace as the treatment protocol. So on the left portion of the screen here, we can see the before receiving the brace, which big rounding of the shoulders, hunching forward, massive sagittal imbalance where she's so far forward, rounding and complete reversal of her lumbar curvatures, which again, as we know, it creates that amount of pressure and that nerve compression into the low back, hence the difficulty walking. On the right portion of the screen here, what we can see is her spine in the brace and how much correction it actually brings. So we can notice a major improvement in terms of how far up she actually holds herself now. And we're starting to see a little bit more of that lumbar curvature, that lumbar lordosis that we've been looking for as well here. With the amount of work that we're going to do with the exercise rehabilitation program to give her a little bit more support into her spine, progressively we're going to be able to teach those muscles and those ligaments to hold this more upright position to make sure that she doesn't have as much pressure in her low back, and then we can stop the progression of that hunching forward position. We always base our neuromuscular education, our postural specific exercises with the X representation, obviously. In this case, again, we have that left lumbar curve for scoliosis and that left coronal imbalance, which is basically a whole shift to the left of this patient's center of gravity. On the second X-ray, we know we have the rounding of the shoulders and that complete reversal of the lumbar curve. For the first X-ray, the first exercise is divided in different steps. Step number one is to create what we call spinal elongation to remove the pressure in this area and help derotate those joints as well. The second step of this exercise is to shift the body to the right to remove the amount of pressure that's sitting right now on that left side. And the last portion of the exercise is to work against that curve here. So realistically bending the body as much as possible against the curve to the left to open up those joints and reduce the amount of scoliosis in the curve in there. The second exercise is mainly based into bringing the shoulders more upright and create more extension into the low back. So it's mainly strengthening all of this area from tailbone up to get more arch, and same thing with the upper back and the mid back to get more strength in here and get more support as well so she can hold herself more upright. The second portion of the visit that we're going to have with this patient is to focus on what we call mechanical traction. Mechanical traction is placing a certain amount of load over a certain period of time to allow those tissues, those muscles, those ligaments to adapt to that new positioning. So in her case, what we want to do, shift the body to the right side and then place some tension right on the apex of that curve here to bend it and open those joints as much as possible. The second traction that we're going to do with this patient, obviously, is doing some decompression so we can have that spinal elongation that we talked about, increasing the pull behind her low back to create gentle arching and get more lordosis in this area, as well as strapping the shoulders back so we can really open up the chest and fight against gravity so we can have more structural support instead of just muscle support.
How long will she wear the brace for?
So for an adult with scoliosis, in her case, she also has a lot of degeneration, a lot of arthritis and stiffness into her spine. We're expecting between 8 to 12 hours on a daily basis. Now we do start progressively, so we have that constant progression, but you can also break the time down per day. So you can do an hour there, break it down here, 2 hours there, so it's not 8 hours straight, which helps with scheduling and wear time for patients. The brace guidelines also said that it's going to be for an adult at least between 2 to 3 years of wear time as well.
How long does traction take?
Traction, realistically, in theory, takes between 5 to 20 minutes. Obviously, the actual change in the structure, the actual ligament remodeling, when we can actually change the structure of the spine, happens at the 10-minute mark, where the ligament starts to increase in terms of elasticity and flexibility, so we can have long-term changes. In this patient case, we're going to progressively start at 5 minutes and then gradually increase the amount of traction that we'll do for her so that she can naturally adapt to this new load.
How often does she do the exercises?
So for that patient and patients in general, to hold and maintain the results and make sure that we improve our chances of success in terms of correction or stabilization, it needs to be on a daily basis and part of a routine. It's like you're brushing your teeth. You do it every day, even though you've seen your dentist in the past. It's the same thing with spinal support, spinal exercises, and in her case with the brace as well.
How will you approach that one leg is shorter than the other?
So on that modified Ferguson x-ray that we took, we noticed that sacral discrepancy. She does have a true short leg, meaning that one femur is actually genuinely shorter than the other one. The best way to approach this to manage that pelvic tilt is to give that patient a shoe lift, which will help balance those levels between the legs and lift that pelvis up so we have a more stable and straight foundation of the spine.
What happens when she's done with treatment?
When she's done with treatment, what we do is that we progressively reduce the wear time of the brace. We also keep follow-up appointments just to make sure that there's no partial collapse, that we still have no issue with the low back. And in her case, we also check on how does she do with her exercise and her routine on a daily basis, because that's the best way for her to maintain those results, is by keeping that new routine, focusing on those new partial habits.